So, welcome everyone to tonight's OTAC clinical case webinar. This webinar is on uncommon opioids that you may encounter, presented by Dr. Darren Roberts, who is very well placed for this presentation. He is an addiction medicine specialist and clinical toxicologist and pharmacologist at Royal Prince Alfred Hospital here in Sydney, as well as the medical director of the New South Wales Poisons Information Centre and a conjoint clinical associate professor at UNSW. I'm sorry, I wasn't sharing my screen. So I'd like to begin by acknowledging the traditional custodians of the lands on which we meet and recognize their continuing connection to land, water, and culture. And I'd also like to pay my respects to elders past, present, and emerging. So just some of the geographical registrations for tonight. We have almost 20% interstate, but a lot of people from the metropolitan areas and also regional representation. And these are just some of the specialties and roles of those who have registered for tonight. So we have a lot of interest in this webinar, which is very exciting. It's the first webinar of the year. Welcome to everyone who has joined tonight. And just a quick tidbit about the OTAC clinical case webinars. So these are monthly webinars that we hold on Tuesday nights. They are recorded and a copy of the slides will be made available on the OTAC website. If you attend the live webinar, we will create an e-certificate for CPD that you can use to self-claim your points. And if you have any questions, please type them in the chat. We'll answer the questions at the end of the webinar because there's a lot of content to go through today. As a reminder, they are recorded, so don't reveal any identifying information. Please participate if you would like. We do have some Zoom polls later in the webinar for today. And now I'll turn it over to Dr. Darren Roberts.
Hi, everyone. Thanks very much for the kind opportunity to be able to present today on this topic, which I think is certainly very interesting and something I spend a bit of my time working on. So I'm sharing the correct slide there, am I, Jessica?
Yes.
Great. Okay, so thanks very much for the kind introduction. I too would also like to acknowledge country. I'm on the beautiful lands of the Gadigal people of the Eora Nation, who are the traditional custodians of the land that I'm presenting from, and I pay my deepest respect to elders past and present and to Aboriginal people here today. I also would like to do a community acknowledgement. A lot of the work that I'll be talking about today is learnings which have come actually from our collaborations and communications and interactions with the community, which relates to people who have lived experiences of drug use. And so I'd like to give an acknowledgement to the community because it's through these collaborations that we gain new knowledge so that we can all have a clear idea about, next steps. So in the way of objectives, by the end of this webinar, we're going to talk about some relevant cases. And so what I like to do with my presentations is to start with some cases just to give a feel for the direction and the vibe, and then go through some information. Then we come back and talk about those cases. So I'll go through these cases pretty quickly. We won't answer them at first, but there is some questions there for you to think about. What we're going to do then is talk about different opioids that I'd consider uncommon. And that relates to the fentanyls, the nitazenes, poppy seeds, kamini, and loperamide. So these are opioids, although they may be uncommon, they feel common to me. I feel like I'm always talking about them and thinking about them because of cases that we come across. And I think therefore you may also have come across them. So we're going to talk a bit about those. And then we'll sort of wrap up very briefly talking a bit about drug surveillance and response and how that works in New South Wales. So moving on to those cases. So this is the first case, and I'm sorry there's a bit of words on some of these slides, but as you know, our patients aren't always, or patients in general aren't always straightforward, which can be summarized by 2 or 3 sentences. So we've got a 33-year-old man with a history of drug-induced psychosis with florid delusions after using trips earlier that day. And he's also been drinking poppy seed tea. He has about 500 grams of poppy seeds. Now, what this means per day? So what this means is he buys 500 grams of poppy seeds. He puts them in with, say, a liter of water, usually warm water, makes a tea from that, and then he drinks the liquid that comes out of that. He's known that sometimes when he gets agitated, his mother even helps him to access the poppy seed, and she makes the tea and provides that to him. So he's come into hospital for a planned admission under mental health, and this relates to this drug-induced psychosis. He's had a urine drug screen, which is positive for crystal methamphetamine, cocaine, cannabinoids, benzodiazepines, but he was given some of these by the ED because he was so agitated, and also opioids. So most things are positive on this urine drug screen. The patient states that he is hanging out, and a COWS is done, the clinical opioid withdrawal scale, and that comes back with 9 to 11. So that's a high measurement. So he's asking for opioids, and the prescriber in the emergency department or the mental health ward has said has offered methadone or Suboxone, and the patient says, "No, I don't want to do that." So the psychiatrist is saying, "Well, why don't we just prescribe him OxyContin 20 milligrams BD and PRN endone?" And so, why don't you think about, is that something that you would agree to? The next question or next case is another case also relating to poppy seed teas. This is a man who's 20 years old, and he's been drinking poppy seed tea for some time. And he has a higher amount. He has 1 kilo of poppy seeds, which he uh, dissolves in the water, and then he drank that between over about 2 hours. After doing that, he felt some epigastric pain, and then some chest pain and tightness, some shortness of breath. And then he just thought, this is not good. I'm going to go to hospital. And he turns up to hospital saying, I think I've got thebaine toxicity. He's not sedated. He's got no tremor. There's no twitching. There's no seizures. There's no muscle pains. He's got a very normal examination, including his reflexes. He's calm and comfortable, but has some vomiting. He's had some blood gases and an ECG, and they're normal. And so someone calls you up and says, what do you reckon? Could this be related to poppy seed tea? Could it be thebaine toxicity? And some of you might go, what's thebaine? A number of us used to say, what's thebaine, until about 18 months ago or 2 years ago. We'll talk more about that later. This next case is about a patient who's has a history of fentanyl dependence due to pain, and it's about how would we initiate the opioid agonist therapy. So it's a 65-year-old woman, chronic arthritis, who's prescribed fentanyl patches for many months. There's concern about her opioid use because when she develops a new compression nerve palsy a few months ago because she fell asleep on the toilet. It's discovered that she's been injecting the contents of the fentanyl patches on a regular basis. Any attempts to wean this in the community has not been successful. In fact, when you log on to SafeScript, she's now got a red flag warning. Her current prescription is fentanyl patches, 100 micrograms per hour every 3 days, oxycodone sustained release, 10 milligrams BD, and some diazepam every now and again if she has muscle spasms. So how would you prescribe this in this circumstance? And the fourth case is about a 28-year-old man who presents to hospital after collapsing, and he's got a background history of taking loperamide. And so loperamide, as you know, one of the brand names is Imodium, 400 milligrams a day, so 200 capsules. So he goes to a bit of effort to shop around the place to find these capsules. He's been doing this for months, but he actually hasn't had any for the last 2 days. So he was actually found in the ED to have a monomorphic ventricular tachycardia. He's given some magnesium and it all seemed to get better. An ECG is done and shows a QRS of 200 milliseconds. A QT is prolonged at 600 milliseconds. He's got some ST wave changes. So he's admitted to hospital. On day 3, his QRS is normalized, but he's still got a very abnormal QT with some ST changes. And then he has a cardiac arrest due to polymorphic VT, which responded to one DC shock. Probably some of you are thinking, I'm glad I don't work in emergency anymore. Maybe some of you are missing it. But by day 5, his QT is now normalized. So it's a very long admission. And so the question is asked, did this actually relate to the loperamide? Is it due to something else? Is he intoxicated? Or maybe it's even loperamide withdrawal. So what's your thoughts on that? So why do we talk about uncommon opioids? We do this because there are many opioids that are used and misused in New South Wales. And while we may know, say, heroin and oxycodone as being perhaps the more common, and certainly they're the more common ones that I come across, there are other opioids that people are accessing and are using, and they may then come to us, whether related to the use of those opioids or related to something else. And it's useful for us to be aware of other sources of opioids and any other special considerations that may go with those. We know that this is a problem for some people. So the opiate treatment program in New South Wales has noted that poppy seed teas, poppy seeds, kamini, and another one called kratom, which we won't be talking about today, have been identified by clients as their primary opioid drug of dependence in recent years. And so because of these substances, they've gone onto the opiate treatment program. So it is an important consideration. We also know that in the last 2 years, if not longer, there's been multiple public alerts within New South Wales and beyond talking about unexpected and unusual opioid exposures or detections and even poisoning. And so that means that it's useful for us to be aware of these because they do exist. And other supports which are available to members of the community and also to healthcare professionals such as ADIS and DASAS also receive calls about these. So I think it's useful to understand. If we step back and think a bit more about opioids and how they're characterized, I think this is a useful thing to do because it helps us to understand some limitation of testing. As you know, an opioid is any drug that binds to an opioid receptor and can have morphine-like effects. And so we talk about opiates, which are derivatives of opium. And here we have morphine and codeine, which are the ones we know the most. Heroin also would sit within this since it's metabolized to morphine and codeine. There's also this other substance called thebaine. And then we have synthetic substances, which also have opioid type effects, but they've got a very different structure. And this is where we have the drugs such as the oxycodones and the hydrocodones that we know, meperidine, which is here is the same as pethidine, fentanyl, and some other medicines that are used in hospitals. And some of our other friends over here, such as tramadol, tapentadol, and then our good friend down here, methadone, and our not so good friend, dextropropoxyphene, and dextromethorphan, interestingly. So there's a bunch of opioids that we do see, and of course over here is buprenorphine. These all have different structures. And if we look at structures, it's important. One of the reasons why structures are relevant because it tells us a bit about how urine drug screens work, which ones will become positive, and why someone can have effects that looks like they've got opiate poisoning, even though they've got a negative urine drug screen. So this is the usual structure of opioids, such as morphine and codeine. So it's these three ring structures joined by an ester. And we can see some similar structures between hydrocodone and hydromorphone. But when we look at methadone and fentanyl, tramadol to pentadol, they've all got very different structures. And this is important because a number of the urine drug screens that we have ready access to work by immunoassays. So they generally look at this common structure when it's looking to see if anything is present. And that's why you can have a positive opioid result on a urine drug screen if they've had morphine, codeine, or anything else from the poppy, but it can be negative even if they've had another opioid such as tapentadol, tramadol. And this is showing the structures of some of the other compounds as well. So these are the fentanyls. So again, you can see it's very different to that. Well, I can see it's very different to that because I did a lot of chemistry and I always enjoyed chemistry. Some of you might just think that this looks like chicken wire or something similar with a whole bunch of different chemical groups off it. But there is a very different structure there. And then if we look at the nitazenes, again, they have some similarity to the fentanyls, but very different to morphine. And so that's why some urine drug screens will be positive for, as mentioned, someone can be exposed to one of these nitazene drugs or fentanyl, but on a urine drug screen have a negative test. To try and help us to understand this, New South Wales Health recently released some guidelines to talk about urine drug screens to help clinicians to better understand the fact that there can be times when someone's been exposed to a drug and get a negative result, even though it looks like it should be positive. For example, those cases I mentioned before, someone has an overdose of heroin, but they can have a negative, sorry, start again. Someone has an overdose of fentanyl, but they can have a negative opioid urine drug screen because of that. But the other thing to remember with some urine drug screens is you can get false positives as well. We don't have time to talk about false positives today. The main point I wanted for you to take away from this relating to urine drug screens is to know that there can be reasons due to differences in structures why someone can have a negative test even though they look like they're showing signs of that toxicity, such as opioids. But there can also be times when someone can have a positive result even though they haven't been exposed. So if you have a result that doesn't quite make sense, just contact the laboratory, get more history from the patient that you're speaking to, or send off for another and more detailed test, such as GCMS, which is readily available from a number of laboratories. Okay, so let's talk about some of these uncommon opioids, and I'm going to start first of all talking about fentanyls. Now, fentanyl, to me, working in drug and alcohol, is a relatively uncommon drug that we see. I don't see that many people who have fentanyl dependence. You might see this in the areas where you work. From a toxicologist perspective, we worry very much about fentanyl because we know that it is linked to the illicit drug trade, and we see lots of problems overseas with people who are being poisoned with fentanyl, where they need bigger doses of naloxone. They can have more severe poisonings from even small exposures. A lot of us know a lot about fentanyl. It's a commonly used drug as both as an analgesic, and in the hospital system, we love to use it both as an analgesic. But even with unwell people, when we're intubating them or if they're in ICU, we use it as a sedative. It comes in various forms. Some of these you'll be quite familiar with. I'm sure many of you working in the community would be very familiar with the patch. In the hospital, we're quite familiar with the injection. I don't know if it's still available, but we used to have access to the lozenges, which was sometimes helpful. It's generally considered to have a fairly short duration of effect. So generally it's gone within an hour or two, and the patch, as you know, can persist for longer even after you remove the patch because the fentanyl sits in the skin and requires time to go away once it's already within that area. This very large volume of distribution, just accept me saying that that's a large number, means that with people who use fentanyl for a long period of time, it can all go into the fat and sequester and sit in there, and then it becomes like a depot where fentanyl is accumulating. And that fentanyl means that once you stop using fentanyl, it may continue to be in the blood. And this is becoming an issue that people are seeing overseas. So in North America, where there's a lot of fentanyl poisonings, because they prefer to use, or more commonly, fentanyl is preferred over heroin. In contrast to what we see in Australia, people are having fentanyl multiple times a day. And so it's a bit similar to being on a constant infusion the whole time, and then it goes into the fat and it sits there. We'll talk more about why that's important later. Some people like to misuse fentanyl. They get a good feeling from it. And it's been well known for some time after the fentanyl patches were first released that there was concerns with misuse. It used to be said that if you worked at a nursing home that you could make a lot of money from recycling a lot of the misused fentanyl patches. Recycling a lot of the old fentanyl patches after they were finished with. And that led to a number of different alerts being put out by New South Wales Health. Here's one from 2020, which spoke about the misuse of fentanyl patches. The fentanyls have been in the media a lot more recently because of the concerns about fentanyl analogues. So these are chemicals which have a structure a bit similar to fentanyl, and these chemicals are considered very potent and therefore can be associated with harm. Carfentanil is one of those examples. There was a lot of fear and angst overseas when carfentanil was being found in some cases of deaths, but also in police seizures, because fentanyl is considered extremely potent. And we had one case of it in Australia, in New South Wales in 2019, which led to us to put out some alerts. For those of you who like to look at images to get a better idea in terms of risk, this is the way that you can think about differences in potency between these different substances. This is the amount of heroin that would be considered sufficient to cause an effect, an opioid effect. This is the amount of fentanyl. Because it's so potent, you need a much smaller amount. And this amount, if you can see it down there, is the carfentanil. So it's just a tiny amount. What this means is that if someone is used to injecting a certain amount of a powder, but it's missold to them as carfentanil, then it's very easy for them to have an overdose because it's just a small amount which is required to cause that effect. Even more than that, as part of its potency, is that you may need very high doses of naloxone to reverse the effect. And that is obviously a concern because people don't always have lots of naloxone on board, assuming they can get access to it. Fortunately, in New South Wales, we only had that one case of carfentanil that was mentioned, but we have had multiple alerts which have been put out for other fentanyl analogues. These are mostly acetylfentanyl. which is one of the most common of the novel opioids that we've seen circulating within New South Wales. But concerningly, what we were seeing with some of these fentanyls was that it wasn't being found in products sold as heroin. So it was someone who, so therefore, in that scenario, it's someone who's used to using opioids. So they may have some tolerance. They may be in a safer environment. For example, they've got people around who are there to help and support each other in case it's a potent batch or something similar. They may have access to naloxone. What we were seeing was that acetyl fentanyl was being found in products sold as cocaine or ketamine, which is really quite a concern. There's another example of one sold as ketamine in cocaine, because these are people who are used to using stimulants, not using depressants. They won't have the tolerance, and therefore they're at increased risk. So this showed us that fentanyls were now getting into the market. And so it's a reminder that even our patients who aren't using opioids, but occasionally use stimulants, can be at risk of opioid withdrawal, opioid toxicity. And therefore, those people should be advised to carry naloxone in the event that they have a stimulant that is contaminated. But what this did show us also was that there were cases of heroin use that was found to contain acetyl fentanyl, that batches are becoming contaminated, if you like. People are used to using heroin. They know how much heroin to use. They've got some feelings of how to use that. And now there is concern about that because it may be increasing. So what does this mean for us as prescribers, as healthcare professionals? I mentioned to you before about most of what I'm talking about, sorry, is about the illicit fentanyl. But there is also some of our patients, such as the case that I put forward of the misuse of fentanyl, which can have similar effects. And in the context of this large volume distribution and what that means is fentanyl going into fat, it means then that people, even after they stop using fentanyl, can continue to have some effects which persist for longer than the textbooks would tell you. And that's because it's all been saturated within the fat. There are cases overseas in the US, a lot of my colleagues talk about this, whereby they have to wait 1 or 2 days after someone comes into hospital and they've stopped using fentanyl until they initiate buprenorphine, because when they do so, the people that they initiate that on develop precipitated withdrawal. And this relates to the persisting effects of the fentanyl that's still in the system. This has led some people to say we should wait a few days until we start buprenorphine and use symptomatic treatment, or maybe use oxycodone as a bridge. Fairly specialized stuff, uncommon stuff. So my suggestion would be that with some of our patients who are on fentanyl regularly, then we should consider whether or not you have a chat with a drug and alcohol specialist just to talk about possible concerns or safety with prescribing. We haven't seen as much in the way of fentanyls in recent months, recent years, so hopefully that will stay the same. When we're thinking about overdose, because we all come across overdoses, then it's always important to continue supportive care. Given that we may need very large dose of naloxone, sometimes it may not work, and we just need to proceed to intubate someone. So that involves not relying completely on naloxone. It also means that after a dose of naloxone that you may need to give more because of recurrence of poisoning. So it's a reminder that anyone who has naloxone in the community should still attend hospital. And because of what I discussed before about the differences in structure, it means that fentanyl won't necessarily be detected on regular urine drug screens because of the different structure. And you'd need to use a specialized or specific urine drug screen, such as the GCMS. Or sometimes if people are testing product, they need to use a fentanyl test strip. This is an image which New South Wales Health has very kindly given me permission to use, and it's showing the number of detections in people with poisonings, but also in products that have been picked up by the police, product seizures that we've seen over time. We can see that the fentanyls increase around 2020, which is when a lot of those alerts were that I showed you. But since then, we've seen the numbers come down, so it's much less common. Instead, what it's been replaced by is these compounds called the nitazenes. Now, note that this 2024 was an incomplete year, so the number would be higher. So what are nitazenes? Nitazenes are a concern for us. We've seen an increasing number of frequency of cases of nitazene poisonings in New South Wales. These are some of the alerts that have been going out. So as shown in that previous graph, it is becoming more of a problem. What we're also seeing in the nitazenes is that people are taking it through different routes than what they're used to. You can see in here that there were some nitazenes that look like karma tablets, alprazolam. There were some nitazenes which were a yellow powder that was sold as possible heroin. Here we even saw a nitazene which is in a tablet with a Red Bull logo on it that was sold as MDMA. So it's quite concerning. We have also seen in people who are seeking heroin. The concern became again so great in terms of the different ways that nitazenes were people were being exposed to nitazene that New South Wales Health released another safety notice warning of the fact that we are now seeing people who are exposed to these nitazenes through vaping liquids. So as we know, with certain groups of the population, particularly younger people, vaping has become very common, has become fashionable, a new habit. And we've seen cases where people have been purchasing a product and not knowingly get nitazenes. Similarly, we've seen some people seeking a nitazene by vape and they've found that. So what are nitazenes? Why does this matter? Well, actually, these nitazenes were first synthesized in 1950s, and some of the earliest studies were produced around then. And there's a reason you haven't heard about it, and that's because they were pretty bad drugs. And we'll talk more about that on the next page. They disappeared then for a little while. And then around 2019, we started seeing them again in forensic and clinical toxicology cases. And those of you who know about forensics, that generally means that they're people who died. So people were dying, and as part of the testing, they found these new compounds or these old compounds back again. And a very large number have been found. I think we're now up to about 30 different types of nitazenes which are detected. And in almost all of these, apart from a couple, we have no experience of how they work in humans. We don't know how potent they are. We don't know how long their effects are. So we know that they have very varying degrees of potency. Some are similar to morphine, but some are much more potent than even fentanyl. And therefore, similar to what I was showing you before with the fentanyls, even a small amount can cause severe poisoning. We haven't had a clear idea in terms of whether or not this potency impacts on how much naloxone we should be prescribing to people. One of the main reasons why nitazenes fell out of favor back in the 50s was because it was noted terribly that they actually caused a lot more respiratory depression than other opioids. And so, as we know, that's the worst of all of the side effects of opioids is the respiratory depression. And so they seemed much more severe. Plus, in addition to that, they seem to cause sedation and also some vomiting. So this is a really bad combination. And so the high rate of adverse effects meant that these drugs that were being developed were no longer used. There's even some laboratory data, although it's unclear how much this applies to humans, that suggests by the mechanism of action of the nitazenes that you may not get as much tolerance to them as you do other opioids. I recall a patient who was admitted under my care who had been purchasing a nitazene for vaping purposes, and then he overdosed, even though he'd been using this for, I think, years, because someone dared him to blow smoke rings. And he thought, oh, I'll give this a go and see what it looks like. And just the act of trying to blow smoke rings meant that he had a larger dose than he was used to. And then he overdosed and fell unconscious. Fortunately, he was blowing his smoke rings to friends who were surrounding him. So they were able to call the ambulance and he was able to fully recover from that. But it's just a marker of how different exposures can lead to different risks to people. So what are our experiences so far in New South Wales? We've had a number of experiences. First of all, with acute poisonings, we've had at least 17 cases of acute poisoning. These were all relatively severe, but most responded to naloxone, so that was useful. We've now had more than 6 cases of dependence where people developed some withdrawal, and some people had quite severe withdrawal. And so we're going to talk more about the implications of that. We saw these use was mostly in young men. Only in about half of these cases, in fact, less than half of these cases, were the people seeking nitazenes. They were seeking something else and they were sold the wrong drug. One person, again, a case I was involved with, purchased what they were told was intranasal oxycodone, but it wasn't. It was a drug called metonitazene. But also some people have purchased heroin, but it was a nitazene. MDMA, that case I told you about before. Some people thought that they were purchasing vaped cannabinoid, but actually it was a nitazene. So it's quite a concern. So we think these are probably more common than we're aware of, and people are at risk of both overdose and also withdrawal. Out of concerns for this, New South Wales Health recently issued some consensus guidelines to try and provide some support for healthcare providers who are looking after patients who are using nitazenes. This is based on a small number of cases that presented, but what it was noted was that these patients generally needed very high doses of opioid agonist therapy. And so the overall considerations were, if possible, if someone is dependent on nitazene develops withdrawal, it'd be best if they're managed in an inpatient setting to help facilitate rapid initiation of opioid agonist treatment, use COWs to guide treatment, and a number of different options were put forward. Of course, our usual favorite is starting on sublingual buprenorphine and changing across to long-acting injectable buprenorphine is something which we consider to be useful. But in some of these cases, even on regular or high dose of Buvidal, it was felt that their symptoms weren't adequately controlled and maybe Sublocade would be required fairly quickly. In some cases, it was felt that they had so much withdrawal despite rapid initiation of buprenorphine that maybe we should consider giving them morphine itself to stabilize them and then change across to opioid agonist treatment as a way of which to keep them in hospital, for example, subcutaneous morphine, which I think would be a very complicated decision because it's outside of what would be our usual way of managing such cases. So I'm less certain on that personally myself, but that's just my thoughts on that one. And of course, methadone or buprenorphine as usual. But if you have someone who you suspect is using nitazenes, it's really useful for us to get tests to confirm that that is what's going on, whether it be the product or a blood sample. And there's a group called PRIZE, which we can talk about later. I could put information in the chat group, which is a New South Wales Health Ministry of Health service, which can help to measure or identify novel substances which may be associated with harm or risk in the community. But always remember that patients should have take-home naloxone if they're using opioids, even if they're patients who weren't seeking opioids and say they're going to stop it or a risk of using polysubstances because nitazenes are creeping into a whole lot of other substances, surprisingly. So what does this mean for us when we think about nitazenes? They are a public concern, perhaps more from an overdose perspective. But based on that experience I told you about last year, there are now people developing dependence and potentially having complicated withdrawals that may require hospital admission for support. As mentioned, they're potent, so a small dose can cause severe poisoning. We do know preliminary information says that naloxone works. So it's a reminder to everyone to have take-home naloxone, to use take-home naloxone. What we are learning is that the effects may not be sustained, and more than 50% of people required another dose of naloxone. So as per the usual guidelines that happens with take-home naloxone, when it is given in the community, please always still call an ambulance and encourage the person to attend to hospital for ongoing monitoring to make sure there's not recurrence of poisoning and death. There was a case in another state who was treated in hospital and then discharged pretty quickly because the person wanted to go home. And again, fortunately, they went home to a loved one who was able to observe that overnight they were snoring heavier than usual, and that related to recurrence of poisoning because the effect of the nitazene was longer than that of the opioid, of the naloxone. Okay, and so next one is poppy seeds. So poppy seeds was a very interesting experience for a number of us. Just stepping back, there's a lot of information on this slide, but the poppy plant is Papaver somniferum, but there's a lot of other different sorts of poppy variants which have poppy extracts in it. So it produces a latex, which you can see here on this poppy plant, and within that latex is a whole range of different alkaloids. A bunch of these are well known to us, such as morphine and codeine. Some of you may remember using papaverine in the hospitals in the old days as a smooth muscle relaxant. I don't think it's used as much anymore. There's some other substances as well, and one of them is called thebaine. And thebaine is a little bit like strychnine. It causes seizures in animals and also humans, it works out. I think all of us have known of a case of poppy seed tea use or misuse, where someone has been using it, develops dependence, and asks for help. And a lot of us, I think, thought this was an uncommon event within the community. What does this involve? I've already mentioned this to you before with when we went through some of the cases. Someone may have, for example, 1 kilo of poppy seeds that they dissolve into 1 to 2 liters of water, and then that liquid is consumed. As mentioned, we never really knew how common this was. We thought it probably wasn't very common. Um, the reason they do this is because around the outside of poppy seeds in Australia, they're not washed. And so they contain the residue, which contains a bunch of those different opioids that I just showed to you. And so drinking poppy seed tea in these large amounts is essentially the same as drinking morphine and codeine. And so people getting able to access this through, and they still are, through having poppy seed teas. And we know that it's not completely benign. Some people have been using this to self-manage medical conditions or mental health concerns. We know that it's been associated with dependence or opioid use disorder and also opioid overdose. This is a website which I do want to step you through because I think it's put together so well, but the background behind it is just so tragic. This relates to parents of a 17-year-old who died of opioid overdose. And he was misusing poppy seed tea. The parents knew that he had an issue with opioids, and then they discovered that poppy seed tea was available. And in their mind, they thought he was actually doing well getting off heroin and using poppy seed tea instead. They felt that it was something that was natural, it was something that was readily available, it couldn't have been that much risk, with that high risk, and yet he died. And this is what their website goes through. It says, hey, guess what? Poppy seed teas contain morphine. Morphine will add to other CNS depressants, such as benzodiazepines. And most importantly, is that there is variability in morphine content. So batch to batch variability of different brands of poppy seed tea, or even different batches of poppy seed tea within the same brand, will vary in how much morphine content there is. And then they go on and say that there has been deaths, particularly of their son, who had his usual amount of poppy seed tea. It was just unfortunate that it happened to be a more potent batch, and he died in their home. And they mentioned there's been similar reports, and then they give some really great harm minimization messaging around this. So I think it's quite a powerful website, but it really comes from a point of sadness. And that was a US site. But we know that this has happened in Australia. As mentioned, most of us are aware of at least 1 or 2 cases that we've been involved with over the years. Turning Point down in Victoria put together this website talking about the harms of poppy seed tea. But I don't think anyone really understood how much poppy seed tea was being used or misused until we had this event late in 2023. And what happened here, this is picked up by toxicologists, was that all of a sudden we were seeing a bunch of people developing seizures which persisted, were refractory to treatment, and we even had patients dying from severe metabolic acidosis from all these seizures. This related to consuming poppy seed tea. And so we won't go through all of these in detail, but New South Wales Health put out a number of different community warnings saying, be careful, these effects occur. And the effects are similar to strychnine: seizures, muscle pain, muscle spasms, cramps, and abnormal movements. So all neuromuscular excitation, not the usual opioid effects that you would expect. And this then led to us realizing that there is a problem with the current poppy seeds, which led to a nationwide recall, and brands that are probably well known to a lot of us were all recalled. So what happened? Well, we know that there is some different types of poppies that exist. And they're not genetically modified. They're just a different variant, and it's called the Norman or the Noman, which is the top one variant. And so what this relates to is that this is the normal developed. For those of you who like chemistry, those of you who don't, you can close your eyes for 2 seconds. I'll be very quick. In the poppy seed, thebaine is the main substance of which everything starts from, and then these different enzymes change it to codeine and morphine. Thebaine, we've worked out, is an excellent precursor to make buprenorphine and also oxycodone. And so there are now these poppy seeds which only make thebaine. They don't make morphine or codeine, and then they're used to produce oxycodone and buprenorphine. And these are meant to be non-food grade, and then somehow poppy seeds from these non-food grade poppies entered the food market, and that's what the problem was. And so we saw these strychnine-like effects. And there's a few different mechanisms that are around. This is just looking at how much was in there. So the red relates to the content of thebaine in the recalled products. Look how high it is compared to how low it normally is. And if we compare that to how much, for example, codeine and morphine we normally see in usual products, much lower. And this might interest you. I mean, 1 kilo of poppy seeds can contain 250, 300 milligrams of codeine, or maybe 100 milligrams of morphine, which I think are really quite large amounts people can access from food. So overall, we had 41 cases across Australia that we're aware of, but there could have been many others. People had a very prompt onset within consuming poppy seed tea of these symptoms. Most people had consumed as a minimum of 50 grams, so it was more like 1 kilo or 500 grams, but 50 grams was enough. Many people went to hospital. And then once we picked this up and we were able to provide information and messaging to people, be careful, there was recall of the products that were affected, it's gone away. So what does this mean to us? I think poppy seed tea consumption is probably more common than we're aware of, and it'd be interesting to hear if any of you have any stories relating to that. There is a risk of opioid overdose and dependence with people who are using poppy seed tea, and I think it's useful to remind our patients who might inform us about that, that this is a risk and people have died, even those people who are experienced. But because the opioids that are in there are very similar to poppies, such as morphine and codeine, then if someone is seeking treatment, then we can just initiate opioid agonist treatment according to standard protocols. We don't need to think about anything different or special. Okay, the next one is about Kamini, which again I think is an interesting story because it's been a story that's been coming and going for some time. And it's not just an Australian phenomenon, it's an international phenomenon. Though that issue I just told you about with poppy seed tea was really only seen in Australia, there weren't cases elsewhere. Kamini, you do a Google search and you can see cases about this overseas. So, what is Kamini? Even back in 2016, alerts were being put out by the TGA about the risk of Kamini. Kamini essentially contains poppy extract, similar to what we're talking about with poppy seeds. It's sold as a Ayurvedic medicine, which can have various sorts of benefits depending on which website you read or what you might read on the back of the packet. And so that means that people may be using Kamini not because they're intending to look for opioids or not even because they are known to use substances at all, but for its health purported health benefits. There's been lots of reports about this in different sorts of media, including the fact that you can just buy these from grocery stores. And these are different sorts of, reasons why it's been promoted. It can help you if you've got sexual dysfunction, and it is seen to be used more commonly amongst men than it is among women, and that may be why. It may improve general well-being or increased alertness, which is kind of hilarious that opioids may cause increased alertness. And there's been a number of reports. This is a publication from the MJA from Victoria, which from 2022, so it wasn't very long ago, which speaks about the number of cases around the place. But it mentions that each tablet could have between 2 milligrams and 20 milligrams of opium. So very similar to the story that I mentioned to you before about poppy seeds, there's marked variability in content. And so someone who might be happy and stable taking a certain dose of Kamini may then get a more potent version and then be at risk. And there's been many cases reported of people developing dependence and requiring opioid substitution. I need to move on. This is some other more promotions which talk about variability in cost, variability in content. Here, one bottle of Kamini contains up to 4 grams of morphine, so massive amounts. And it continues to be a problem. Even in 2023, we're still seeing cases. We've seen cases in New South Wales of Kamini, acute overdose and also opioid dependence. And as I mentioned earlier, people have been commenced on the opiate treatment program because of the dependence. We've also seen some people have had mildly elevated levels of lead. So if you do come across someone who has been using Kamini regularly, then it might be useful to explore if they've got symptoms of heavy metal poisoning and or do a screen because of poor manufacturing means that this is present. So what does this mean for us then as prescribers? Products sold as health foods can contain opioids, and this applies that opioid use is not always the intended goal. So we need to maintain an open mind to different sorts of exposures that may contribute to people getting opioid exposure and becoming dependent. And again, that reminder of the batch-to-batch variability. Management, as with poppy seeds, is relatively straightforward. We're talking about poppy extracts, morphine, codeine, so therefore we can just initiate as we ordinarily would in terms of usual products because it's short-acting. But to remember that there may be other metals present. And it might also be useful to inform the Ministry of Health that you're seeing cases. Okay, the last case that I'm going to talk about is loperamide. Loperamide is an opioid that we're really watching at the moment because you can buy it from service stations. So there's very limited oversight about loperamide, and yet it is an opioid agonist. It's a non-prescription opioid agonist used to treat diarrhea, as you know. If you take the regular prescribed dose of up to 16 milligrams a day or 8 capsules or tablets, then you get very few in the way of CNS effects. But we have seen in the US and also in Australia, but I don't think it's very common, increasing uses or misuse of opioids where people are taking very large amounts, so 100 or 200 tablets or capsules a day. The main concern with loperamide is that you get this cardiotoxicity, and it causes QRS and QT prolongation. And research that we've been doing here through the Poison Centre, where we've seen a number of these cases being referred to us because they come into hospitals so sick, such as the case I told you about before, require a prolonged hospital admission because it's got a very long half-life. Loperamide and its active metabolite have half-lives more than 24 hours. So they're going to be in hospital unwell for days. As mentioned, I don't know how common it is. So if you have seen cases, please let me know. The most important thing, and I'll move on from that, the most important thing I want to mention here is that if you have someone who has symptoms, an abnormal ECG, or they say they're using loperamide and they're having collapse or fits or faints, always do an ECG. It's an excellent screening test. If it's normal, that's reassuring. If it's abnormal, it may be loperamide, and they may get recurrent events. There's a bunch of other uncommon opioids that we see also, such as kratom, dihydrocodeine, but we don't have time to talk about those today, maybe another time. Just very lastly about drug surveillance and responses in New South Wales. New South Wales Health has really put a lot of effort in recent years to developing this very comprehensive program to surveillance and to pick up these sorts of compounds so that we can get information that can then be fed back to the community and fed back to healthcare providers just to say, here is some information which may impact on your management and your care. It's really a great process that New South Wales Health has. I think it's one of the best in Australia, if not leading the world. Okay, back to those cases then. So this is the first case, and so it's just hard to do this on my screen. Let me move this across. There we go. So the case was a 33-year-old man known to use poppy seed tea. His mum sometimes even gives it to him. He's come in with what's thought to be drug-induced psychosis that's been blamed on a trip. UDS is positive for everything, including opioids, which is not unexpected given that it's opioids work. The UDS is for poppy-derived things. This is a poppy seed tea. Sounds like he's withdrawing. Someone wants to prescribe OxyContin and endone. So what do you think is the most likely diagnosis in this man? I think here we go. The quiz is up. So if everyone wants to have a vote, I'll let Jessica decide when we share results.
I'll give it another 10 seconds. Okay, I'm going to end the poll now and I'll share the results. So about 55% chose opioid withdrawal.
Great. And about 35% thought maybe thebaine toxicity, and some thought cannabis-induced psychosis. Yeah, so he does have psychosis, and maybe I didn't ask that question very well. But the question, I guess, was more to do with his current symptoms of concern, which relate to the high cows and him hanging out. He's going to be going under mental health. Relates to, is this consistent with opioid withdrawal? And in my mind, yes, it is consistent with opioid withdrawal. And that was the answer that I was looking for in this. Thebaine toxicity would be more associated with seizures and muscle pains and chest pains. Oh, sorry, less so chest pains. It's more the muscle pains and the aches and the increased reflexes and sometimes seizures. And as you know, we do see that a cow's, you can have myalgias and arthralgias. So you could see that there could be some crossover. This guy hasn't actually used the Poppy CT for a little while. So this is looking for us to diagnose opioid withdrawal. And what treatment would you suggest? So he's declining methadone and buprenorphine. The psychiatrist admitting him says, let's just prescribe oxycontin. This is a real case. I'm not just having a go at psychiatrists at all. Please don't think I'm being mean. It's just a real case. So what are your thoughts about what treatment? Oh, can we go to the next quiz? Sorry.
I've pulled the quiz up and people are.
I can't see that one. Let me go back then.
I'll end it and share the results so that you can see it.
Okay, thanks. So we have, so some of you were going to give OxyContin, some of you want to give methadone as per usual guidelines, some are going to give subcutaneous morphine and then transfer to methadone or buprenorphine, some are giving buprenorphine as per guidelines, and some will give symptomatic treatment. So what do I think on this? Well, as you know, the answer in most things in medicine and healthcare in general is depends. There's not always a clear, perfect answer, but my preference would be just buprenorphine, would be to offer buprenorphine as per usual guidelines. It's usually our first go-to. But of course, patient uh, uh, preference is also important. They may not want buprenorphine, might want methadone or symptomatic. I would not be going for OxyContin or endone. That isn't an approved treatment for opioid agonist therapy or opiate substitution treatment, and that dose is just a guess. And I also wouldn't be giving subcutaneous morphine. That is something which I don't think I would ever prescribe to anyone. But I put this in here as an option because it was mentioned as part of nitazenes. Um, so the options then would be to say, I think I'd try to talk to him to say, we don't prescribe OxyContin. It's not what we do. The best options would be for buprenorphine or these to see if we can talk him around. I can see some of the comments saying he declined it, and I agree. But we say the only options to you are, in my mind, in my practice would be buprenorphine or methadone or symptomatic treatment. If you'd like to share your thoughts on that. Sorry, that's what I would say to the patients. Did we want to talk about that, or should we just move on with the questions? Noting the time. I think we'll have to move
I
on.
think probably keep going with the questions.
Yep. I might go over this one because this one is more of a distraction. This person had a bunch of symptoms and he was aware of thebaine toxicity. But really, none of his symptoms relate to intoxication or withdrawal. I think he just had some symptoms which were due to something else. So I'm going to move on from that one because I think that's perhaps just takes up time. It's less important. What are your thoughts on this one? So this is a woman, we talked about the 65-year-old woman with arthritis, prescribed fentanyl patches, she's got a compression nerve palsy, she started injecting a fentanyl, she's getting red flags, she's now presenting looking for help. So our first question here is, what's the total daily oral morphine equivalence for this patient's opioid prescriptions? A lot, yes. I can't see the quiz isn't changing for me, so I'll wait for Jessica.
I've shared the result.
Ah,
If you can't see it, so we have 8% who chose answer 1, 31% who chose answer 2, 23% chose answer 3, 8% chose answer 4, and 31% chose answer 5.
how interesting. So to me, the answer is 3. There'll always be a bit of variability. It probably depends on how you calculate your oral morphine equivalents. I use the Faculty of Pain Medicine app, which is a free download, and I find it's very user friendly. And it allows you to look at different opioids and different routes of administration, and it calculates about 330 milligrams of morphine. I guess it's always useful to think about things in oral morphine equivalents because it helps to standardize the numbers so that we're not confused by different numbers. It's generally said that more than 100, you've got an increase, 100 milligrams a day of oral morphine equivalent, then you've got an increased risk of adverse effects. And particularly if it's above 300 milligrams a day, then you've got an increased risk of death. So this person is on a very high amount of opioids. So, we don't have the next question there. Next question was going to be about what do you do, but that's okay. And this last case was about loperamide poisoning. I'm just going to go on and tell you the answer to this one. The question here is, do you think this is effect due to loperamide intoxication, loperamide withdrawal, or unrelated to loperamide? The answer to this is this relates to loperamide intoxication. He's got high concentrations from the misuse of the loperamide for a long time. It's got a very long half-life, and therefore he's going to be unwell in hospital for days. So anyone who tells you they're misusing loperamide, get an ECG. If abnormal, I would be calling an ambulance and sending them to hospital because they've got unpredictable effects. Obviously, it depends on how severe it is. So what are the future trends in opioid use in New South Wales? Look, I don't know. I mean, obviously, these things are changing all the time, and we're learning new things all the time. And so we just need to have processes in place which allow us to monitor for changes. We know that the different things are happening all the time to the drug trade, and we're seeing changes. So my concluding comments are heroin, after looking at all these, isn't heroin just seem much less complicated to manage and look after? We're all practiced with using heroin. I think we know what to do, but some of these have other considerations. There's some drugs that are emerging. We need to watch this and think about how that impacts on how we manage our patients, and always need to provide good clinical care.
Thank you everyone for joining today, and thank you again to Dr. Darren Roberts and also Sharon Reed for monitoring the chat. Have a good night.